basivertebral plexus ablation. Definitely another procedure of the anterior column that has been a game changer. We're moving away from kind of the non-specific low back pain mentioned that we were hearing a couple of years, 10, 15 years ago, to very specific pain generator that we can target and completely disconnect and decrease the pain drastically for patients. So it has been a real game changer for a lot of practice, definitively in my practice. We know how costly low back pain is and chronic low back pain is. And even previously, prior to understanding all the neuroanatomy, a lot of patients with chronic low back pain still had other unresolved pain generators. So even at 2 years post-diagnosis, we could not really understand why a patient had chronic low back pain. So chronic low back pain is also very costly for any payer. So basically, we're talking that the 15% of patients with chronic low back pain will cost payers in healthcare system about 75% of healthcare costs. So we need to find a reason and the source of low back pain and treat it accordingly. When we're talking about vertebrogenic back pain, it is very frequent. And prior to understanding the anatomy of the vertebrae, that was, I think, one of the source of pain that was increasing the cost for the healthcare system. So since BVNA, I expect now and moving forward, we should be seeing solutions for this type of back pain and also decrease in healthcare costs because we have a permanent solution. So about 15% of patients with chronic low back pain will have some component of primary vertebrogenic pain. That's about 5 million patients in the US. It's a large contributor to low back pain. When we're talking about vertebrogenic pain, obviously it's coming from the vertebrae, so it is an anterior column pain, so pain that patients will describe whenever they're sitting, bending forward. But in comparison to other type of pain, it is a very midline pain, pain that will be also activity related, and normally you can really discriminate it from other type of pain, such as fastogenic pain, so no pain with palpation of the paraspinal soft tissues, less pain with hyperextension. So really midline and anterior column type pain. What's the innervation of vertebrogenic pain? It is coming from the basivertebral nerve. So as you can see here, it is you can appreciate a arborization of nerve that starts from the end plates that will go toward the apex of the basivertebral nerve, and the basivertebral nerve will exit through the ostium, have some communication with the sinovertebral nerve. There's other type of neural contact either through the main trunk. There's also deputy branches that can exit directly, but the majority pass through the main trunk and will go back through the pain afferents back to the brain. This has been a ongoing work since the late 1990s. So Antonoshi and Brown, basically, that really were pioneered to discover that nerve into the vertebral body. And since then, we've noted the link between modic changes that we'll talk very shortly and that nerve in the pain afferent back to the brain. So interesting enough, this is a nerve that we see on every MRI, right? So you can see the plexus here and the foramen in which you have a nerve, a vertebrae, a nerve, an artery, and a vein. And now that we have actually a reason to ablate it, a lot of radiologists and neuroradiologists are paying way more attention to those findings. There is also a correlation between the amount of density of nerve that will be seen along the end plates and the degree of damage. So the more bony erosions, the more intense the modic change is, and the larger amount of neural density you will have through the end plates of those patients will have more significant amount of pain. When we're talking about modic change, there's three type of modic change, so type 1, type 2, and type 3. Type 1 and type 2 can be treated with BVNA. The type 3, which is mainly sclerosis, that is not a imaging biomarkers that we're following or that we want to treat. The modic type 1 represents swelling or edema within the end plate, so will be bright on T2 imaging and hypointense on T1, versus the modic type 2 that represent more a fatty infiltration of the end plate, so that will be bright on T2 and bright on T1 imaging. What's the prevalence of modic change in a pain practice? Is this something that we see fairly frequently? Well, we did ask that question, and we reviewed in our centers 1,060 lumbar spine MRI prospectively of patients that had chronic low back with or without leg pain. So we reviewed thoroughly all segments and at 3T MRI. And in average, in all those patients, 43% of patients had modic changes, so treatable source of low back pain, which is a big deal. Obviously, this is a subset of patients that already have back pain, so the prevalence within the general population is closer to the 15%, but it is a large contributor to the patients that we're seeing through our doors in pain clinics. Average age of patients that have modic change is about 55 years old. And in terms of also type of modic change, so you have the modic type 2, that is the most prevalent source, modic change that we see, followed by modic type 1, about 30% of patients. And the majority of those modic changes were seen at L5S1. So the level L5S1 is the most frequently affected by those changes. Modic change is binary, so either it's present or it's not present. This is very important to get approval for the procedure. So we were talking earlier about collaboration with other healthcare providers. Well, it's very important to work closely with your diagnostic imaging provider or radiology colleagues. It needs to be described and properly mentioned within the reports from the L3 to the S1 level. It needs to be detailed as modic change for you to get approval for this procedure. This is something that we talked about in the first paper in 2020, and we republished actually through ISAS in 2022. We reviewed basically the literature overview and also what was the required mention in MRI reports and clinical indication to be able to proceed with basivertebral plexus ablation. So these are patients that needs to have at least 6 months of trial of failed conservative care with axial pain pattern and that modic type 1 or type 2 change from L3 to S1. Followed by other societies that followed our first policy paper in 2022. So after that, there has been ASPEN, NAS, and SIS a bit more recently that also heavily supports this procedure. So we have level 1A evidence. This is a highly published and studied intervention. So really high level of data that we have for this procedure. There's also ICD-10 codes that were developed in 2021, so M5451, and 2 CPT codes, 64628 and 64629, that allows to proceed with the intervention. Again, a lot of data that supports the utilization of BVNA. Multiple clinical studies, systematic reviews that document this good procedure. One that is, I think, of importance to mention that has been recently published, so that presented the 5-year pool outcome of 3 prospective clinical trials, so the SMART, the Intracept, and the single-arm BVNA. What you can take out of those 250 patients that were followed for at least 5 years is that 66% of patients at 5 years have at least 50% pain decrease, and 33% of patients had complete pain relief at 5 years. So really very strong results for after this intervention. The opioid use also that dropped drastically in those patients, and the amount of other intervention as well. And throughout that 5-year pool review of 3 RCTs, they pulled together 33 clinical sites. So that's a lot of sites, lots of different providers. And if you compare the curve of each studies up to 5 years, you see really a trend that everyone is obtaining the same results. And that's really telling that independently of the provider, of the site, we obtain the same consistent result in terms of pain decrease in the NRS and also in ODI in function. Often there is some mention that, some of those research studies were sponsored by the industry, while we have 2 also prospective studies that were non-industry sponsored at all, and they obtained exactly the same results. So that is actually this one, the Vivo, that was published in 2020. Different system, different providers, different ablation time and parameters, and they obtain exactly the same results. So a decrease in VAS of 4.3 and also an ODI in 32.4. So that's really telling also that this is a procedure when you burn that apex of the BVN, it does provide long-lasting pain relief. A more recent also industry independent paper that demonstrated the same results. So 77% of patients had at least 2 points reduction in VAS, and 68% had at least 15 points of reduction of ODI. Little tips and tricks. Again, this has been a procedure that really changed my practice. In terms of patient selection, I was talking to one of the fellow during the break. Interestingly, with those 3 important papers, so the SMART Intracept and the single-arm cohort, they reviewed the pain diagram of all the patients that were included, so the 250, to try to determine what type of pain pattern predict good outcome after basivertebral plexus ablation. And it is really that midline anterior column pain. So in comparison, the patients that did not had any facetogenic components, so no pain with hyperextension, no pain with palpation of the paraspinal soft tissues, those pain do very, very well. The other piece of information that came out of those 3 studies was the imaging biomarker. So what type of modic change do we find to be able to select adequately patients and predict good outcomes? Well, if the patient has a modic change, especially a type 1 of at least 50% of the width of the end plate, those patients tend to have a very, very good outcome after the ablation. What's a not so good imaging biomarkers? Well, if you see facet joint effusion, so that fluid within the joint, those patients had actually a odds ratio of less than 1, so of 0.5. So that was actually a imaging finding that was suggestive. Well, you should probably consider doing a medial branch block, potentially facet joint blocks, or concomitantly treating both the anterior column and the posterior column. So those patients will have some type of facetogenic pain. In terms of technique, it has been very well described. So there's recently actually, Ipsis just published a paper demonstrating different techniques, advantages of each techniques. So you have a transpedicular approach, you have a parapedicular approach as well. Both are very quick, very efficient. The parapedicular technique, actually, Dr. Beal did a significant amount of work on this approach. In 2007, published a really great paper that reviewed 102 cadavers and demonstrated how this space, the parapedicular space, is aneural and avascular, very quick, very easy to access. So those 2 approaches can be utilized. The parapedicular, obviously, if you have any type of transpedicular screws, or if you have adjacent level degeneration with modic change, well, you need to pass through parapedicular approach. So very similar type of approach. We'll be able to review those approaches also in the cadaver lab very shortly. Where do we want to create this ablation? So right in the center of the vertebral body on the AP view, and about 1 centimeter in front of the posterior wall on the lateral view, as you can see here, between 30 and 50% of the AP dimension of the vertebral body. So this is true for L3 to L5. For S1, S1 has a little bit of a different anatomy. Dr. Yoon will be presenting the axis very shortly. So normally you want to have a nice 30-degree Ferguson tilt to be able to really align the superior end plate of S1. And there's different type of approaches that we'll be able to review in the lab as well. The target site is a little bit different at the S1, so about 40% under the superior end plate of S1, and about 50% are a little bit more ventrally located at the S1 level. How do we ablate this nerve? Well, there's a concept called CEM 43, which is a cumulative equivalent minute at 43 degrees Celsius. So how do you reach 100% cell death after an ablation? So currently the ablation protocol is 85 degrees at 15 minutes, but depending on the system and how you perform the ablation, there's some optimization to be made as well. So this is something that different groups are currently working on to try to shorten the time as well. What does it look like after an ablation? Well, you can see really those target ablation sites. Early on, some radiologists that were not comfortable with the procedure may have thought that these were lesion or metastases. These are really classic BVNA ablation sites and very well located along the apex of the BVN. At 6 months and 12 months, interestingly, in animal model, if you follow those animals after ablation, you notice that there is no nerve regrowth. That means that this is a permanent pain relief. The BVN is non-myelinated, and for that reason, once it is injured, it will not grow back. So this is one of the beauty of this procedure. Patients now in the first since 2016, 2018. There's some patients that are very close or even past 10-year follow-up and still have complete pain relief. So in conclusion, vertebrogenic for chronic low back pain, very prevalent. We discussed this earlier. Modic type 1 and type 2 needs to be diagnosed and mentioned within the radiological reports to be able to proceed with reimbursement. We can use fluoroscopic guidance and some techniques also on CT guidance. We can use a transpedicular or a parapedicular access. Different type of RFA system can be utilized for treatment. It is a midline pain that is a good prognostic for the procedure. So again, anterior column and midline pain symptoms. And if you have facet joint effusion, consider adding potentially radiofrequency ablations or other type of facet treatments. Thank you so much.
Questions, comments?
All right. I have a question. Sorry.
Please go ahead, yeah.
But so many questions. Please, anyone, stop me, if there are. I have further, if either you and or Dr. Beal could expand in terms of perpendicular approaches and vascularization, in terms of lumbar segmental arteries that do run kind of in those regions. I asked that because one, I think about vascular injury, and I know with other peripedicular approaches with pedicular access, for kyphoplasty, there are cases of iatrogenic hemorrhage with lumbar segmental artery injuries. I'm just curious, what are your pearls for evaluating pre-procedural imaging? And
So we have one question, then we're going to move right on to the lab. Okay, guys?
Yeah, it's a great question. Basically, one of the statement paper that Ipsis just published, they were saying, well, if you use a transpedicular approach, you're way closer to the central canal. If you use a parapedicular, you're close to other anatomical structures. If you're really on the parapedicular space. Normally, it is avascular and inaural, so you're staying away from everything. But just like everything, you're going to have cross-sectional imaging before the intervention. So no matter what what type of approach you're using, take a look at your approach. But we'll review it in the lab. It is a safe approach. I would say probably half, or probably 95% of my thoracic vertebral augmentation, I use a perpendicular approach, and I would say probably half of my lumbar one, and I never have any of those complications. It is extremely fast. I would say even faster than a transpedicular approach, and the reason is you're right along the posterior wall of the vertebral body. But again, you're pretty much at the junction between your pedicle and the posterior wall. So there's a corner there that you have absolutely nothing. If you take a look at a lot of lumbar MRI, you don't have a lumbar vein or lumbar artery. You don't have nerve there, so it's a very safe. But I'll let Doug make a couple comments. He worked on the technique there.
So anybody can have a hematoma if they're anticoagulated, and people can have hematomas where you cut yourself shaving, and if you're anticoagulated enough, you'll die from that. So the issue about the segmental artery, if the vertebral body is from the bottom of the desk to right here, the segmental artery is right here in the middle. I mean, you're not ever going to go down to halfway down the vertebral body to get in. And it's always, when it's compressed, it pushes the artery down. So we've done thousands and thousands of these without any issue. And if somebody has a hemorrhage, you can have a retroperitoneal hemorrhage just from putting in an interspinous spacer. I mean, from very little intervention, the main problem is the anticoagulation, either iatrogenic, meaning you have problems with medications, usually anti-inflammatories that we don't think about, or liver dysfunction, things like this. So, I mean, the perpendicular approach is exceedingly safe. And anybody who's warning you about hitting a segmental artery, think twice about taking advice from them for a vertebral augmentation approach.
Yes.